Hi there. Welcome to the Addiction Medicine Podcast, brought to you by the Governor's Institute. I'm Amy Johnson, Director of Communications at the Governor's Institute. In today's episode, we're diving into a critically important topic, opioid treatment programs in North Carolina, what they are, how they work, and what's being done to expand access and reduce stigma across the state. Joining me is Anna Stanley, the State Opioid Treatment Authority Administrator for the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Use Services. Anna, thanks so much for being here with us today.
Thank you for having me.
Let's start with the basics. For listeners who may not be familiar, what exactly are opioid treatment programs and how do they function here in North Carolina?
Yeah, so our opioid treatment programs are state and federally licensed facilities that offer all FDA forms of medication to treat opioid use disorder, as well as other supportive services like counseling, case management, peer support, and referrals to other resources. We call our opioid treatment programs OTPs for short, and they're the only level of care where patients can receive methadone for the treatment of opioid use disorder. Medications for opioid use disorder, or MOUD, as they're called, is the gold standard of care for the treatment of opioid use disorder. And in fact, for opioids, when we consider the efficacy of all treatment options, a recent study out of Yale found that treatment of opioid use disorder without medications is actually more harmful than no treatment at all. And that means that it's actually safer from an overdose perspective for people who use drugs to continue using them than to engage in an abstinence-based treatment model where they receive medically managed withdrawal, which is commonly known as detox, and then they're placed in a long-term rehabilitation environment without access to buprenorphine or methadone. And another interesting thing that we're seeing on the ground here in North Carolina is that with the infiltration of fentanyl and its derivatives into our street drug supply, we are finding that initiation on methadone can sometimes be easier than initiation on buprenorphine just because of the slightly different way that the medications interact with the opioid receptor sites in the brain. But both medications are extremely effective at reducing the risk of death, with methadone reducing the risk of death by 38% and buprenorphine reducing the risk of death by 34%. Now, historically, OTPs have been clinics where patients have had to go every day to be observed taking their medication, so they are considered a higher level of care than, say, getting your buprenorphine prescription from a prescriber in the community. However, a lot has changed about the regulations since COVID-19, and so we are seeing the time our patients are spending in the clinic before they can get take-home medication drastically decreasing based on their individual needs and their treatment.
And how has the landscape of OTPs evolved in North Carolina since COVID-19? What does the data tell us? How many are there? Where are they concentrated? And who do they serve?
Yeah, so we've seen 25% increase in the number of OTPs in our state just over the last 5 years since COVID. We currently have 94 licensed OTPs, and that includes 2 state-operated inpatient facilities and a tribal-run program that's operated by the Eastern Band of Cherokee Indians. In the past year, we have served about 32,000 unique individuals in our OTP system. Even though currently our OTPs are physically located in 53 of our counties, we actually serve patients that reside in all 100 counties. And we are very deliberate in our state strategic plan around MOUD saturation, so we really want methadone to be accessible in all 100 counties, either through OTP expansion or strategic community partnerships with OTPs. And as far as the breakdown of demographics served, our patient population is 84% white, which is very overrepresentative of the demographics of the state. We've also have a lot of work to do with outreach related to our Black and Hispanic communities. They are very underrepresented in our OTP treatment system. But listeners can check out where all of our OTPs are located on our North Carolina Central Registry at thecentralregistry.com/map.
Thanks, Anna. That's a great website, and we will give that information again at the end. So despite their effectiveness, many people still face real challenges in accessing treatment. What are some of the most pressing barriers to access that you've seen?
Yeah, I think the most obvious barrier is actually not having a treatment option in your area. We are fortunate in North Carolina that 57% of our patients travel 10 miles or less to get to their OTP. But the further out that you get into the counties that don't have an OTP option, we do see that travel distance increase. And that can be a real challenge, particularly if you're having to come to the clinic every single day. We also have a good number of patients that travel over state lines to come to treatment in North Carolina because we do have greater access here. And when I think about why we don't have OTPs in every county in our state, I think that the biggest barrier to that is stigma.
Yeah, I'm glad you mentioned that. So that continues to be a major obstacle, stigma, both in communities and healthcare settings. So can you talk a bit about how stigma impacts someone's decision to get treatment and what's being done to change that?
Yeah, stigma surrounding opioid treatment programs is deeply rooted and multifaceted, and it stems from a combination of historical misconceptions, societal biases, policy decisions, and misunderstandings about addiction and MOUD in particular. And so here's kind of a breakdown of what I see the main reasons are for stigma that continues to exist. So the first is moral judgments about addiction. Addiction is often seen as this moral failing or a lack of willpower rather than what it actually is, which is a chronic treatable medical condition. And people who use opioids, especially those that have severe opioid use disorder, are frequently stereotyped as dangerous, irresponsible, or criminal, and this can carry over into the places that they seek treatment. A second piece of this stigma is this misunderstanding of MOUD and methadone in particular. Methadone has a long history and is sometimes viewed as just replacing one drug for another. I think that there is a widespread lack of understanding that methadone and buprenorphine actually stabilize brain chemistry and they support recovery. It's not just trading one addiction for another. It doesn't support continued drug use. Another piece to our stigma is visible patient population. So many of our OTPs serve patients that are in acute stages of their recovery. And they may have co-occurring issues such as housing insecurity or mental illness. And because these patients are often visiting the OTPs daily and they're in centralized locations, this can make the programs more visible than other types of treatment. And it invites this idea of NIMBY or not in my backyard attitudes coming from the communities. We also have some historic regulatory segregation that's taken place over time. OTPs are subject to strict federal and state regulations that separate them from other healthcare settings. And this is evident in things like, daily dosing and observed administration of the medication and the fact that the DEA is overseeing these programs. And this regulatory framework has historically isolated our OTPs from mainstream medicine, and it reinforces this perception that these patients and services are different, And then I think finally, media and cultural representation has not been kind to our OTPs. Movies, TV, and the news even often portrays our OTPs as bleak and chaotic, and it reinforces negative stereotypes rather than highlighting the success stories or the science behind this medication for opioid use disorder. And I think that it's become sort of this self-fulfilling prophecy because due to that stigma, people often don't realize that millions of Americans have actually returned to work and rebuilt their families and recovered their lives through OTP services. They're just too scared to talk about it. And so what can be done now? I think that reducing OTP stigma requires us to do things like education about the science of addiction and MOUD. It requires policy reform. We need to integrate our OTPs into the broader healthcare system. We need to ensure community engagement. We need to highlight the benefits of OTPs and reduce that NIMBY resistance that I talked about before. And I think we really need to center the voices of lived experience of both our patients and our providers to share the stories of recovery and hope that exist every single day.
Yeah, that's great. A lot of work to be done on stigma. Transportation, Anna, is another major challenge, right? So especially in rural parts of the state. How does that factor into access to OTPs, and are there strategies being used to close that gap?
Yeah, we actually have found that some of our counties are using opioid settlement funding to impact transportation barriers. So county grant funding can be used to purchase things like bus passes and Uber rides or even replace tires on patients' vehicles so that they can get to treatment.
Oh, that's great. Let's shift to policy. How have federal and state regulations impacted OTP operations in recent years? And are there any changes that have helped improve access?
Yeah, so prior to COVID-19, our state and federal rules were very arbitrary and rigid. They relied heavily on this time in treatment to earn your take-homes, and North Carolina statute was actually much more stringent than federal statute, and it would take patients years to earn the privilege of taking their life-saving medication home with them so that they didn't have to come to the clinic every single day. But the COVID-19 pandemic significantly impacted the operation of our OTPs, and they had to quickly reduce the number of patients that were attending the clinic in order to comply with things like local mandates and to protect vulnerable patients and staff. We had social distancing, there was reduced access to public transportation, and there were required quarantines and isolation that made it really difficult for our patients to actually come to the program every single day. And so now suddenly the OTPs had to weigh the risk of COVID-19 transmission in their decision on whether or not to provide take-homes. And so regulatory bodies, including SAMHSA and the DEA, temporarily relaxed certain regulations to accommodate those challenges that were posed by the pandemic. And this included increased flexibility in take-home medication policies and the use of telehealth services. And North Carolina immediately registered our concurrence with the new federal guidelines for COVID, and our OTPs shifted to begin providing more take-homes and requiring patients to attend the programs much less frequently. And we found that, as a result of those flexibilities, the telehealth buprenorphine admissions allowed for much greater access to treatment, and take-homes led to greater retention in treatment. And several reports noted the benefits of these regulatory flexibilities included enhancing patient-centered care, improving provider rapport with their patients, increased patient autonomy and engagement, and a mixed method study found that take-home dose flexibility among stable patients was associated with receiving more take-homes, higher rates of treatment retention, and lower rates of opioid-positive drug tests. And patients in that study reported that the increased number of take-homes actually supported their recovery because they felt trusted by the staff. They spent less time traveling to the program, and that permitted increased time spent on work and recreation. And several studies also indicated that the prior concerns that a lot of people had about the impact of these increases in take-homes would result in, methadone diversion-related problems and methadone overdose deaths, but those did not appear to have happened. While our OTPs were able to provide patients with the new maximum number of take-home doses, several studies found that OTP staff use their discretion in determining who should get additional take-homes. They know their patients the best. And so SAMHSA took all the lessons that we learned from the COVID-19 public health emergency, as well as decades of research around methadone, and they made those flexibilities that we saw during COVID-19 permanent in April 2024. And this was the first substantial update to OTP treatment standards in over 20 years. And in North Carolina, we're also in the process of updating our current OTP rules, but in the meantime, we're actually requiring all of our OTPs to obtain a waiver from our state rules so that they can follow the federal guidelines, which expand access to care, and it improves patient experiences as they seek treatment for opioid use disorder.
North Carolina's Medicaid expansion is a big deal. How has it affected OTPs and access to medication for opioid use disorder, and what concerns exist about its potential instability?
Yeah, when North Carolina launched Medicaid expansion in December 2023, it increased Medicaid access to 600,000 North Carolinians. And we saw the burden of treatment for opioid use disorder shift from state funding to Medicaid funding. And that allowed us to provide treatment across our state to way more people. And currently, 61% of all of our patients that are enrolled in our OTPs are covered by either Medicaid or state funding. And these services don't just save lives, they save money in the form of reduced ER visits and reduced incarceration. This medication helps people get back to work and school and their families. And if Medicaid is cut, we expect that many people will lose access to their life-saving medication for opioid use disorder. And the fallback option is usually emergency rooms and jails, which is not only ineffective, but it's expensive. And we know that every dollar spent on treatment through Medicaid saves up to $7 in other costs, such as emergency care, policing, and lost productivity. When people have access to the care that they need, overdose deaths go down, families stay together, and communities become safer and healthier.
On a more hopeful note, let's talk about innovation. How are you and others in the field working to destigmatize OTPs and integrate them more fully into the broader healthcare system?
Well, the new rules have created a huge paradigm shift in the way that we think about the services provided in the OTP. It's been a huge shift away from this rule-based and dictated treatment to a much more individualized approach. The old way of doing things reinforced the stigma for our patients and for our OTPs. I mean, in a lot of ways, our OTPs were victims of the silos that the system created. And so in my role as the SOTA, I'm doing a lot of education, both to our OTPs and to the communities at large, about the new standard of care. Our new rules are about breaking down the barriers to treatment and recovery. Our OTPs are their community's resident experts on the treatment of opioid use disorder. They are positioned to be amazing community partners and a larger part of the healthcare continuum.
And we've also been hearing more about mobile OTPs and medication units. Can you explain how these models work and what impact they're having, especially in settings like jails, community health centers, and local health departments?
North Carolina has approved mobile and medication units, which are extensions of the brick and mortar OTP. And just like it sounds, the mobile units are on wheels, and you can think of them kind of like a traveling OTP, but they are parked at designated and approved locations. Med units are stationary, and they're usually in a less populated area or a community location like a local health department or a federally qualified health center. And these are exciting additions to our new rules because they grow the footprint of the OTP to help us expand to areas where we had less access. And my hope and dream for North Carolina is that we have methadone access in all 100 counties through partnerships with our local detention facilities. Right now, 48 of our jails actually allow OTPs to provide methadone to inmates. I want our OTPs to have partnerships with their local community health centers and local health departments to make sure that every North Carolinian who needs access to this life-saving medication has it.
That's great. Looking ahead, what are some of the most promising developments in OTP delivery, either here in North Carolina or from other states or countries?
We're doing some great things in North Carolina. There are many areas where the OTPs are embedded into the infrastructure of their communities, and partnerships are ensuring that patients get access to their life-saving medication. I'd say that the most promising developments are the flexibilities in the rules to allow OTPs to really be patient-centered in their approach to treating opioid use disorder, the allowance for mobile medication units, and overall lower barriers to access of treatment through telehealth admissions and a removal of requirements for unnecessary thresholds.
If you could change one thing about how OTPs are perceived or operated in North Carolina, what would it be?
I would just want people to know that it's not your parents' OTP. Times have changed and regulations have changed, and we have a much more permissive regulatory structure that really allows our OTPs to be good community partners.
And finally, what gives you hope about the future of opioid treatment in our state?
What gives me hope is that for the first time, North Carolina is aligning policy, funding, and compassion in the same direction. Medicaid expansion has opened the door for hundreds of thousands of people to access evidence-based care for opioid use disorder, many for the first time. And we're seeing mobile units on our roads, peer support in our clinics, and a shift away from punishment and toward dignity. And it's not perfect, but we're no longer debating whether to treat addiction. We're asking how to do it better and how we can do it with humanity. And that gives me real hope for the future of opioid treatment in our state.
Anna, thank you so much for joining us today and for the work you're doing at North Carolina's State Opioid Treatment Authority to improve access to life-saving treatment across the state.
Thanks so much for having me. It's been a pleasure.
And thank you to our listeners. If you'd like more information on the OTPs in North Carolina, go to thecentralregistry.com/map. That's where you'll find all the OTPs in our state as well as contact information for them. And if you enjoyed this episode or learned something new, be sure to subscribe to the Governor's Institute's Addiction Medicine podcast and share it with a friend or colleague. For more resources, visit governorsinstitute.org. Until next time, I'm Amy Johnson, and this has been the Addiction Medicine Podcast. Have a great day.